Okay, so let's get it started. So the topic, as I mentioned, would be infertility slides for young academics and professionals. In the beginning, I talked with our friend Hamed Fatahian, who is also a psychologist, and I mentioned that this is a very sensitive topic. Should we have this topic in such a setting? He also encouraged me to have such a setting, but he mentioned that we would have acknowledgement because this is a very sensitive topic. So I really want to share this with you, that this we all understand that this is a topic of fertility and infertility that can be deeply personal and emotional. Our goal is to create a supportive, empathic space where we can openly discuss these important issues. Whether you are here for professional knowledge or personal insight, know that you're not alone. We all have friends, family members, and belief systems that support us. And this community is here to do the same thing. We hope you find this seminar informative and uplifting. So we have two guest speakers. First will be Dr. Asiai, and then next would be Dr. Khan. So let me introduce briefly, briefly mention their bios here. So Dr. Asiai has a medical degree from Brown, a master's in public health from Harvard, and an OBGYN specialty training from Harvard. Following her specialty training, she completed a fellowship in minimally invasive gynecologic and robotic surgery under the world-renowned Dr. Kamran Nashat, where she trained to perform advanced laparoscopy and hysteroscopy. Dr. Asiai has a special interest in reproductive immunology, unexplained infertility, pregnancy loss, fibroids, endometriosis, PCOS, I hope I mentioned that correctly, and uterine abnormalities. She is a member of the Freya, is that correct? Freya, Early Pregnancy Loss Clinic. She will stop doing, I think this is the extra explanation. Dr. Asiai was nominated into the Gold Humanism Honor Society for incorporating humanism in the practice of the medicine. Her philosophy of care centers around emphatic and personalized care, where her patients will feel validated and heard. Dr. Asiai speaks Persian, of course, and but today, and also French too. And this is her contact information, and she was kind that she asked me to share this information with you. So in case that you would have any question, you would be able to reach her. We are going to have a second speaker that will join us after Dr. Asiai's talk, and after her talk, we will have a Q&A. So Dr. Wajiha Khan is an experienced licensed marriage and family therapist with over 18 years in the mental health care field. She earned her PhD in organizational leadership at the Chicago School of Professional Psychology. Dr. Khan holds a BA in psychology and a MS in counseling from California State University. And she's highly skilled in crisis intervention, relational challenges, child development, and supporting young adults. A strong advocate for community-based care, she brings both compassion and clinical expertise to her work. And as you can see, both of them are really helping the community. Dr. Khan is also part of a Bay Area community. Used to live here, still should be close by, but she was not able to come in person. We are honored that we will have her and also Dr. Asiai for this session. So now I want to invite Dr. Asiai for her talk.
Thank you all for having me. Last week was Infertility Awareness Week, so we wanted to try to put this together pretty quickly in the past week, just to honor that and to help educate the community and offer any help and services about this topic that may be needed. So since this was the Quran group that invited me, I did want to mention that there are mentions of infertility in the Quran, actually in several places. So this is one ayah Moshe Bakhan is going to read for us, and then I'll start our talk.
So I found that I have an app that actually can read
perfect.
perfectly better than me. So I will play from the app with the translation in English.
يخلق ما يشاء يهب لمن يشاء إناثا ويهب لمن يشاء الذكور. To Allah belongs the sovereignty of the heavens and the earth. He creates what he wills. He bestows female offspring upon whom he wills, and bestows male offspring upon whom he wills. أو يزوجهم ذكرانا وإناثا ويجعل من يشاء عقيما إنه عليم قدير. Or he bestows both males and females in the same womb, and he renders barren whom he wills. Indeed, he is the omniscient, the omnipotent.
So this is not a new problem, right? This has been an issue that has been going on since we've all existed. And I did want to just highlight this slide here where we show 1 in 6 couples will experience infertility. So think about this room. A number of us, unfortunately, may experience this. Yes. Full screen. Full screen? Are you doing it from that screen? Full screen at the bottom. Yeah, thank you. So the objectives today is going to be to understand the common risk factors, learn how infertility is evaluated, review available treatment options, and explore prevention strategies. Definition of infertility is no conception after 12 months of trying to conceive. And there's primary infertility, which means that the couple's never been able to conceive. And there's also secondary infertility, where a couple has been able to conceive and then has trouble to conceive for a second child or a further child. And there's various causes. Oftentimes we think of women carrying the burden of infertility, but when you actually look at statistics, you have about 1/3 of the population of women as the main cause of infertility, 1/3 being male infertility, and then about 20% being both the male and female partner having a contribution to the infertility, and then about 20% that remains unexplained. In terms of the female risk factors, we have to look at the reproductive system to determine where there can be issues. And so really you can have issues in any part of the reproductive tract that could lead to infertility. Here's the ovaries over here. Then you have the fallopian tubes, you have the uterus, and you have the cervix. And the way that conception actually occurs, if we just want to start from the basics, is once you have sperm introduced into the uterus, it has to travel through the fallopian tube, capture the egg that was ovulated that month, create the embryo, which happens at the distal end of the fallopian tube, and then the embryo has to travel back through the tube and implant into the uterus. So it's pretty miraculous that this actually ever happens correctly. There's a lot of things along the way that can go wrong. So first, looking at the ovaries, you can have failure to ovulate. That's like the #1 thing that has to happen is you have to have the egg released. So there's different situations where that won't happen. As we age being one of the major factors, egg quality and egg quantity is going to decrease. The number of eggs that a woman is born with is actually the maximum number of eggs she's ever going to have. And unfortunately, that just continues to go down as we age every single year. So things like waiting, anything that's going to make you wait to get pregnant is going to ultimately potentially cause you infertility. You know, waiting to get your degree, waiting to get married till you pick the right partner, just unsure if you want to have kids, and then later you decide. You know, there's so many things that may get in the way of that ability to conceive right away at the age where it might be prime. Abnormal BMI, so being overweight, but also for women in particular, being underweight can also stop you from ovulating. So really having the BMI in the normal range is very important. Premature ovarian insufficiency. There are a lot of women I see, they come in their 30s, they're trying to conceive, it's not happening. And then we find out actually their eggs are as if they're 45 years old already. And they're already going through menopause. And it's pretty devastating to figure that out right when you're trying to conceive. So something else to just be aware of, and why it's a good idea to start thinking about fertility or testing for fertility, maybe even before you're ready to try to have a baby. PCOS, a condition where multiple follicles are growing in the ovary, but there's not a dominant follicle that grows. And so you never end up ovulating, and you can go months without ovulating. So if you're not having regular cycles, that could be a sign of PCOS. That's something you should get investigated by your OBGYN as soon as possible to rule out. Thyroid issues can also cause trouble with ovulation. And there's other things like prolactin disorders as well. So the next part that can be an issue would be the tube. So the fallopian tube can have diseases like an infection that's caused blockages or scar tissue that causes the embryo to be unable to travel back into the uterus. You may have heard of an ectopic pregnancy. That is often caused by scar tissue or damage to the tube. So the embryo gets stuck here, and those embryos, those cannot continue to grow. They put the mother's life at risk, and those pregnancies have to be removed. And sometimes the mom or the patient will lose her tube. Endometriosis, that's one of my focuses and my specialty. It's a condition where we see what we call ectopic endometrial tissue. So tissue that the cells that look like the lining of the uterus are found in other places in the body. So we see it on top of the uterus. We see it growing through the fallopian tube. We can see it on the diaphragm. We can see it on the spleen. We can see it in the lungs. It's a very strange disorder. And anytime a woman is cycling, that tissue will also bleed and get inflamed. And so you get a lot of inflammation in the belly. And it has symptoms of having painful cycles, painful periods, painful intercourse, lots of pain. And so if that's something you're experiencing, you should also see your OBGYN, because it's one of the key points I want everyone to know is that it's not normal to have painful periods, which is unfortunately something that we are told that it's normal and it'll be fine, but it is a major cause of infertility to have endometriosis. The next thing would be an issue with the uterine body. So you can have fibroids, which are benign tumors that grow within the uterus. And if they're pushing into the endometrial cavity, which is this area here, the embryo can have a problem implanting, or if it does implant, it won't have a good blood supply. It can also have polyps, which cause the same problem. Scar tissue in the uterus, where the uterine walls are just glued together. There's also something called a uterine septum, which is pictured here, where you have a heart-shaped kind of in the heart-shaped uterus. And again, that blood supply is not good when the embryo implants there. Next, you can have immune issues. So if a woman has autoimmune thyroid conditions, lupus, once the embryo does finally implant, you need your immune system to be functioning properly to allow that to flourish and grow. And then I mentioned with endometriosis already, but just to highlight it once again, this is a condition that causes chronic body inflammation. It can cause scar tissue all over the pelvis. It can affect egg quality. It can affect tubal function. So it has an effect in every aspect of fertility. In terms of male factors, we look particularly at the sperm, we'd look at a semen analysis to look at the sperm count, motility, morphology, but there's also structural issues. So a varicocele needs to be ruled out, hormonal imbalances. There's also several genetic conditions, and there are many men who don't find out that they're even a carrier of these genetic conditions until they're struggling to conceive and have a karyotype done, which can also be very hard to deal with later on in life. Klinefelter syndrome is one of them, cystic fibrosis, Noonan syndrome, Kallman syndrome. And then lifestyle factors, just like they affect the woman, can also affect the man. And obesity is one of them for men that can decrease testosterone levels, smoking, alcohol intake, the use of steroids. So if you are on anabolic steroids, that would be something you want to stop. Also, a warning to avoid taking any extra testosterone. Some men take testosterone, and this can actually decrease the amount of natural testosterone that you make in your body, affecting the ability to produce sperm. Excessive caffeine has also been shown in several studies to affect the sperm as well. Environmental factors like heat, radiation, toxins have been implicated as well. And so heat is one to keep in mind, in particular for the men, avoiding saunas, hot tubs, very tight clothing. Sometimes bicycling can also cause that. So if you do a lot of bicycling and you find that there's an issue with sperm count, that's something else to cut back on. So really trying to keep your body temperature at a normal level as much as possible. Common toxins I put here, there's pesticides, phthalates, so plastics, try to avoid using plastics. We now have a lot of information on how microplastics can affect fertility, BPA, heavy metals. And these common toxins also apply to women. So when do you want to begin the evaluation? So if you want to look at the textbook, what the textbook is going to tell you is that you should start the evaluation after 12 months of trying if you're less than 35 years old, and after 6 months of trying if you're greater than 35 years old. And they're talking about the woman in the situation, and sooner if risk factors are present. And the reason they get these numbers is because of this graph that I put here. And as you can see, for women, there's a decline that begins shortly after 30, but it really starts to go down faster after 35. And that's where I see all the women in the back, their eyes are looking very concerned. We're going to get to the different options we have. But yes, there is a pretty drastic decline. And this is something that we need to be aware of, because there are different reasons, like I mentioned, why, we may not be ready to start our fertility journey in our 20s, but this is the reality of it. And then for men, there actually is a decline too. It starts in the 40s, but more drastic in age 45 and later. But as you can see, it's not as severe as we see in the decline for women. So given this, I want to actually say that the best time is any time. You don't have to wait 12 months. And like I said, there's certain things that you find out during the fertility workup that a lot of my patients say, I wish I had known this 10 years ago. Like, why didn't I do this test 10 years ago? And then I would have potentially frozen my eggs or tried with my partner sooner instead of, starting that job right away. And there's really no reason why you can't start the fertility workup. You may need to advocate a little bit for yourself, because if you're seeing a doctor who is very by the book, they're going to tell you, well, you're not infertile. You haven't tried for 12 months. Try and come back in 12 months. But as you'll see, some of the workup is intense, but some of it is just blood work. And we do blood work for fewer things than, something this important. So I would actually advocate for testing sooner if having a family is something that's important to you. So the female evaluation will go into a bit. It's quite extensive. You don't usually start with everything at once. Obviously, you'll get a history, do a physical exam in the office, check for cycle regularity, which is going to indicate if you're cycling regularly that you are ovulating, which is step 1. Rule out any infection history, any surgeries in the past that may have affected the tubes. Things like having a ruptured appendix, for example. You may not realize this, but having that can cause scar tissue in the pelvis that would cause the tubes to be blocked. So there's things that may seem unrelated, but actually would affect your fertility. Lab work you want to get are listed here. Most of it's hormones that we want to check. These are done on the 3rd day of the cycle, typically. And AMH is an anti-Müllerian hormone. That's a really good test to see how far you are from menopause. And so this is the one that we use, that's used a lot also in IVF practices to kind of see what your response to the IVF is going to be. And it's a nice thing to just to check and know where you're at. Because like I said, sometimes we get surprised and we check a woman's AMH at 30 and it looks like she's 45, which can be quite devastating. And maybe it's the other way around. Maybe you check it and it's really good. Then you can feel a little less stressed about potentially having, having more time to conceive. Prolactin and then karyotype is checking your genes to make sure that you have a normal number of genes and there's no translocations that could cause issues with pregnancy. The imaging starts generally with a pelvic ultrasound. And then there are more advanced testing like the hysterosalpingogram, which is pictured here, which is a test that looks at the tubes to make sure that the tubes are patent. And what they do here is that there's dye that's inserted into the uterine cavity, and then there's an X-ray that takes place, and we check to see if the dye is able to exit both tubes. And so in this one, we're seeing that there's spillage of dye in the cavity, so we know both tubes are open, because like I said, that sperm has to travel and then the embryo has to travel back. So if you don't have functioning tubes, it doesn't matter how great the sperm is or how great you're ovulating, they're never going to meet. So this is really important to make sure that that tube is there. That's the highway for them to actually meet and get you pregnant. So that's one test that's very important if you haven't been getting pregnant after a few months of trying, to make sure that the tubes are functioning. The saline infusion sonohystogram is an alternative test. Instead of using the dye, we put saline into the uterine cavity and we do an ultrasound. And there are air bubbles that can also be inserted to see if the air bubbles are leaving the tube. So it gives you the same idea of whether the tubes are open. And then both of those tests also give us a picture of the cavity so we can make sure there's not that septum that I talked about. Because if there is a septum that's very large, that really does need to be treated before you try to conceive. Ovulation tracking is often what I start patients on when they want to try to conceive, to, again, like I said, step 1, make sure you're ovulating. And this will tell you how to time your intercourse too, so that you're during your fertile window. Sperm stays around for 5 days, but the egg only stays around for 1 day. So what that means is that you really need the sperm around when you ovulate in order to actually have a conception. Trying to conceive even 2 days after you ovulate doesn't matter. Those 2 weeks mean nothing. It's really that week after, which is usually cycle day 10 to 14, which is going to be around the most fertile window. But again, everyone's different in terms of their length. So you want to start tracking your cycles and using these ovulation predictor kits, which are available over the counter or online, to track exactly when you're ovulating. And then keep for the doctors to be suspecting endometriosis, or even you as a patient, if you do have symptoms of chronic pelvic pain, painful intercourse, painful periods, to tell your doctor and to make sure that they have endometriosis on their radar. And then the laparoscopy and hysteroscopy are kind of the end stages of the evaluation. They're more invasive. A laparoscopy is an incision into the belly button with a camera placed through the abdomen to see the abdominal cavity and the pelvic cavity. And then often, if there are abnormalities like the endometriosis lesions, we'll excise them and remove them to help treat the inflammation. Hysteroscopy is a camera into the uterus to make sure that there aren't any fibroids, polyps, or that septum, and we can treat those. The male evaluation is a little shorter. So we have the history, medications, exposures, surgeries, any history of varicocele, things like that. Imaging can check for varicocele, so that's done with an ultrasound, and this is usually done with urology. So OBGYNs do not do this part of the workup. You would need to see a urologist to have that done. Lab work as well, checking hormones, and then genetics to checking a karyotype. And the semen analysis, some OBGYNs will actually get that part ordered for you. So typically we'll start with the female evaluation, and then we'll get you started with the semen analysis. If there's anything that's looks very abnormal in the semen analysis, we'll refer you to a urologist for the remainder of this workup. And this is an example of the things that were most important on a semen analysis: the count, the morphology, and the motility. And I always joke with my patients, you know, the women only have the one egg, and it has to be a really good egg. But thankfully, you guys have like millions of sperm. So oftentimes men get a little scared when they see there's only like 3% normal morphology, but that's all you need, because you have so many. So you have a lot to spare, thankfully. Treatments. So the treatment is tailored to the underlying causes. We talked about lifestyle issues that can cause infertility, so making sure you implement that, addressing hormonal and anatomic issues, and then going to assisted reproductive therapies like IUI, IVF if needed. And in case you don't, I'll go through exactly what those are in case you're unfamiliar with those. But the first step is usually if a woman is not ovulating, to help her ovulate, and there's medications we use for that. So clomiphene, letrozole, gonadotropins, and these are going to help a woman cycle, so that, and sometimes that's all you need. So it can be as simple as a medication for 5 days. Medications for males who may have issues with low testosterone or issues with the sperm, HCG, clomiphene, and then often also some supplements as well to help. CoQ10 is a good one. You know, oftentimes I'll just have women and men take CoQ10 while they're trying as well. If we find that, you know, they've tried naturally, we've tried these, you know, first steps, and they're still not pregnant, then we'll start talking about things like IUI, which is intrauterine insemination. Basically, the sperm is collected outside in a lab, and then it's introduced with a catheter into the uterus on the day that the woman is ovulating. And so the rest of the process happens naturally. The only part that the doctor is intervening in is introducing the sperm, and it's going through the cervix, so we know it's getting into the uterine cavity, and the sperm itself gets washed, and so you get a bit of a higher quality sperm. So if you have an issue with the count or sometimes with the motility, morphology, we see that after the sperm washing, these values can improve. And so those are the two things we're bypassing with IUI. The rest of it has to happen naturally, though. So the sperm still has to go through the tubes, still has to connect with the egg, still has to come back and implant. So it is overall a pretty natural process, and you still need everything else to be functioning well. The next step, if that's not working, usually you'll do a few rounds of the IUI before you move on to other things. And insurance in the past actually required this, although there are some changes now. But if after 3, 4, 5, sometimes 6 times you try an IUI and it's still not working, you'll often then move on to IVF or surgery. And with IVF, just to give you a quick summary, a woman will take injectable medications generally and super ovulate. So instead of just releasing the one egg, we give so many medications so that she'll actually make 20 eggs or so. That's kind of the goal. And sometimes it's not 20. You may get 5, you may get 30. But the goal is to super ovulate that cycle. And then there's a surgical procedure. It's done under anesthesia where the eggs are retrieved. At the same time that the eggs are retrieved, the specimen is collected from the partner, and the embryos are made in a petri dish, and then they're grown out typically up to 5 days or so, and they can be tested for genetics at that point. So this is the only process where we actually can get genetics tested before transferring an embryo. And at that point, most of the embryos are frozen, or all the embryos are frozen, and then one or two is chosen to transfer into the uterus. So this is much more medicalized and procedural than anything else we've talked about. But it does improve chances of success quite significantly. About 50% of the time we have success with IVF. And this is done with a specialist called a reproductive endocrinologist and infertility specialist, REI. So that's actually a different subspecialist than I am. ICSI is another technique that is used particularly if there's sperm issues and you want to select the best sperm. So this is something that's added on with IVF, and the sperm is actually introduced directly into the egg. And so that's even more controlled than letting the sperm just migrate into all the eggs and create embryos. Next step, potentially either before IUI and IVF or after, if these haven't worked, would be surgery. And this is a laparoscopy to treat endometriosis because of all the issues we talked about that it can cause, or to treat tubal disease. So sometimes we'll do the HSG and we see that the tube is very dilated with fluid, and that causes a lot of inflammation that affects the ability of the embryo to attach to the uterine wall. And so some of the REIs will refer patients to me just to get the tubes removed, so then they can do IVF and have a higher chance of success with IVF. So it sounds a little counterproductive because we've just talked about how important the tubes are, but now we're saying we need to take the tubes out. And that's because with IVF, we've bypassed the need for tubes. We're taking everything outside of the body, making the embryos outside and just putting it right into the uterus. So we've taken out the whole transport highway situation that we talked about. And it actually shows in studies that taking out a diseased tube improves the chance of IVF. So there are times where we will actually take out your tubes to get you pregnant. And then myomectomy for fibroids. So if they're large fibroids, sometimes we need to remove the fibroids to improve fertility as well. If all of this doesn't work, there are still other options. Some patients opt for donor sperm, donor egg, and gestational carrier. So using a surrogate. So a gestational carrier, you still have the genetic DNA of that couple, but you're using another woman's uterus to carry the pregnancy. So those are some other options. Now, obviously, prevention is better than cure. So how do we prevent ourselves from getting in a situation where we need to use all these treatments? Maintaining healthy weight, all those lifestyle things we talked about, avoiding smoking alcohol. Thankfully, in our religion, that's already a big part of it. So we have that covered. Decreasing caffeine intake, managing chronic illnesses, diabetes, thyroid disorders, making sure you're seeing the doctor for routine checkups for these things. STD prevention, STI prevention, limiting exposures to toxins, plastics, BPA, things like that. Limiting heat exposure, particularly for men, and then starting to try to conceive as soon as you can, or consider cryopreservation. Now, you don't want to have a baby when you're not ready to have a baby, or you may not be able to, you don't have a partner. So it's not always an option. Maybe you have a divorce and now you're 35 and you're starting your family later because you're waiting for your partner. So there's so many reasons why you may not be able to try when it's ideal to try. So one thing to really think about is freezing, which is egg freezing, sperm freezing, or embryo freezing. It's known as cryopreservation. For egg freezing, ideally before 35. So I tell a lot of my friends, if you're not married by 35 or even 33, 34, give yourself a number, freeze your eggs. Yes, it's costly. It's about $10,000 if you don't have insurance coverage. But it could save you a lot of heartbreak, and it could give you a chance at having a baby in the future. It's not 100%. Egg freezing is relatively new compared to embryo freezing, but we are seeing success with it. And there are other reasons why egg freezing may be recommended. Besides holding off on fertility for personal reasons or your career, you may have a cancer diagnosis and you may need chemoradiation. So both for men and women, this is often when REIs recommend egg and sperm freezing, so that, again, you can preserve your option to have fertility, even if you're undergoing these treatments that can disrupt that. For sperm freezing, I did highlight here, it's easy, non-invasive, there's long-term viability. In contrast to egg freezing, it is a bit more of a process. Unfortunately, having the ovarian stimulation, there's pelvic ultrasounds every 2 days for about 2 weeks. And then you have the surgical removal with the retrieval under anesthesia. So it is something to prepare yourself for. It takes a little bit more preparation than the sperm freezing. You have to have a good 2 weeks off, or at least flexible with work. But it is something to just keep in the back of your mind as an option. Embryo freezing has been around longer, and the chance of having a successful thaw and viable embryo is much higher with embryos than with just the egg alone. So if you have a partner, if you guys have option, you don't want to have kids now, I would recommend considering embryo freezing as opposed to freezing egg and sperm separately. And some people even do embryo freezing and they keep some eggs as well. So there are different variations of this, but very important to consider. And timing matters. I think we've stressed this a lot, but I do want to just bring it up one more time. This graph on my left shows the effect of a woman's age on estimated monthly pregnancy rates. And so again, we see this pretty sharp decline after 30, and then in particular after 35 for women. And so thinking about egg freezing, if you're not in a point to have a baby by that point, is very important. And on the other side, we have pregnancy rates by treatment type. So IUI, IVF, both of them, the chance of success decreases also by age. So just because you have IVF as an option doesn't necessarily mean you have 20 more years to wait. You still want to consider, well, the egg age is very important. So if you did freeze your eggs at 20, you do have a better chance of success for IVF than if you froze them at 38, for example. And you can see that with the donor egg IVF line, because the donor eggs are often very, like much younger, like 20s, early 20s. And you can see how that really does help in terms of the chance of success. But at the same time, there is hope. Even if you haven't frozen your eggs or embryos at this point, or you're not in a position to try for a baby now. This is an article that just came out March 6th of this year, showing that there's a large shift. It's a historic shift where now for the first time, we actually have more women delivering after the age of 40 than in their teenage years. So this, you know, overall, the fertility rate has decreased, but this shows us that there's still hope, even if you are conceiving later, or, you know, you decide that you want to start for a family later. And this is mostly due to the advances in technology and assisted reproductive therapies that we have. So just wanted to end again with the ayah from the Quran that says, and bear in mind that your riches and your children are nothing but a trial, and that Allah alone lies the highest reward. So if anyone is out there, you know, struggling, you have support. You can come to communities like this, you can talk to your doctors, but ultimately, you know, our faith is something that carries us through all of the trials in life, regardless of what it is.
Thank you so much. So we are going to have the Q&A after Dr. Khan's presentation. So I hope, Dr. Khan, could you unmute yourself?
Sure. Assalamu alaikum.
You can share your screen, or if you want, I can just show the presentation, whatever you prefer.
I can share the screen. Let me see.
Okay, so let me stop sharing.
Let me know if you can see the screen.
Not yet. Yes, it's coming. Yes, we can see you. But yeah, we can see you now, but we cannot see this the screen that you have shared. Oh, is it? Oh no, this is my screen. So what I can do, I can share my screen. Oh, it's coming. Yeah. Okay, here we go.
Do you see the full slide, or with the notes or without?
No, we see exactly what you see. It is with the note.
Okay.
You are exactly see what you're seeing on your screen.
Okay. Doesn't know why.
Better, but at the same time, if you can go to the present. Which one is this? That present in Teams, not that one. There should be a, underneath in the bottom, you see that
All the way to the left.
all the way to the left. Yes. Yeah, just
This
click
one?
on. Yes, please.
Okay,
Very good.
well, all right. Well, I can't see any of my notes and I don't know. That's fine.
So
No
what I
worries, we can-
do, I can share that myself and you
Mhm.
tell me next slide and I will show the next slide. Would that work better?
Sure. Okay, let's do that. Let's do that.
Okay. Sounds
Let me
good.
stop sharing here and then
Sharing, and then I
we
can
can
share.
there. Yeah, no worries, no worries. Appreciate it. Okay. Anyway, thank you, everyone. I know this is Friday night. This is getting late for everybody, but I really am so thankful, grateful that Dr. Azadi and Dr. Asiai have invited me here to, present and share a few coping strategies and, support as a therapist. And this is very this topic is very near and dear to my heart. And so just wanted to introduce myself. I'm Wajiha Khan. I'm a licensed marriage family therapist and put together some slides, it's really, I was told, this is a gathering, just informative, but also, informal and we can, talk and have any questions answered. It's really meant to be a very supportive gathering. So I didn't want to, that's why I put some pictures there just to kind of make it interesting and just let you know that I'm here to mainly introduce myself and to also introduce support for everybody.
Excellent.
So navigating
sister,
infertility, yes, go ahead.
So I just wanted to mention that in this room, right now there are more than 40 people listening to you, and there are people online. So we appreciate you
Nice.
coming, and so you definitely are helping us. Thank you so much. Yeah, go ahead, please. I just wanted to give you a perspective of the room that you cannot see.
Thank you, doctor. I know I cannot see the room, but I'm sure everyone can hear me, and I appreciate that. Thank you, doctor. Okay, so we can go to the next slide. Just again, introduction of who I am. I'm a licensed marriage family therapist. I've been in the Bay Area since 1978, long time. And I have been practicing for over 25 years. And I worked in community-based organizations and hospitals and universities, private practice as well. And I recently have started my own practice. And so I'm the founder of Well Mind Therapy in San Ramon. Most importantly, I have life experience with infertility. And we'll talk more about that, and which is why, again, this is such a topic that is so near and dear to my heart. And I'm able to relate to a lot of couples coming in who are dealing with infertility. So I'm really honored to introduce myself today to everybody. Next slide, please. So again, the main purpose of our meeting today is to offer emotional support and resources. We can talk about some of the emotional impacts of this journey. It is a journey. We can talk about coping strategies and different resources. Of course, I'm familiar with Alameda County and the resources out here, but there are plenty of resources in your area there in Santa Clara County or Palo Alto area. And I will share those as well after a few slides. And then, just some questions and any discussions around this topic, I'd be more than happy to answer. The next slide, please. Okay. These are some natural emotions. And, when we experience different things during infertility, or not even during. It could be things that come up even before the thought of starting a family. It's some anxiety around what ifs, because there's always a what ifs. And then when you're, if you're dealing with infertility, then you have a lot of these different natural emotions. And it's important to really look at these different emotions that come up, because it is grief, loss. I mean, there's so many emotions. These shame, anger, guilt are just a few. Um, Anxiety and depression. I mean, once again, these are natural emotions, and acceptance of these natural emotions help, to reduce anxiety. Every month it is a loss if, women's has not conceived. It's a loss of hope. It's a loss of some dreams of starting a family, and then, the anger associated with the lack of control that we feel in experiencing infertility. So it really impacts our relationships because we are so consumed with the process. And so these are natural emotions that are experienced. And the first step is to really, we'll talk more about it in the coping section, but to accept that these are natural emotions, natural, normal emotions that are associated with the journey. I have indicated a book here for your, for a resource. It's called Unsung Lullabies, Understanding and Coping with Infertility. So, and there are plenty of resources out there, just to search the internet, but this is one I wanted to share with all of you. Has been very supportive, helpful, and is a great resource. Okay, the next slide, please. So there's some other impacts of the process, and so other impacts due to infertility are communication breakdowns, differences in coping styles. We also have intimacy disruption and financial and logistical stress, as well as social pressure and isolation. So these are some impacts that exhaust us during this journey. I mean, they're really exhausting us. And I'm not trying to say, these impacts are completely negative. I'm just saying they're impacts, they're adjustments. Due to different life changes, we are having to adjust. And we continue to try to cope and adjust and create solutions. And so together with your partner, you create these solutions and accept each other as two individuals trying to cope in different ways. We all cope in different ways. There isn't just like one coping mechanism or style. So this is a big one here where I really support couples in trying to understand what those coping styles are, and it's really helpful to clarify. And then when we talk about social pressures, well, that's coming from everywhere. You have social pressures such as, family members and friends trying to suggest a certain treatment or a medication or a certain prayer or a certain food to eat. It's just like, then you got, of course, social media is telling you so many things. Drink this smoothie and you'll have a baby. Or I don't know, like there's just so much out there and it's overwhelming. One part of that is, well, wow, okay, there's a lot to be said and I don't feel alone. But then you see that, others are successful and then you feel isolated and, it just causes more grief. So it's an impact. It impacts your day-to-day life, and it's something to acknowledge. Of course, family members and friends are all trying to be supportive. But at the end of the day, you're the one experiencing these emotions. Okay, the next slide. So this is about coping now. So back to coping. How do we cope? What does it mean? Everyone has a different way of coping, and everyone has a different way of defining what coping means to them. So sharing your story helps to validate your experience. It is your story. And I think it's important to share your story with people that you trust, people that would acknowledge you, would support you, uplift you, and and because you're really holding that story with you, your emotions and your struggles and your concerns. I do want to share that in the beginning I said I have life experience, um, and with this topic. So yes, I've been through everything that Dr. Askia was talking about. I was just talking about my life right there, because it's very it's a process. It really is a process, and during each step of the way, you are feeling all these natural emotions, and it is so important, which I was unable to have at that time. We're talking about 25 years ago. Um, and by the way, Alhamdulillah, I have two boys, 24 and 21. So, there's always um, hope, and I did have that. I held on to hope, and that's how I coped. Was just okay. I have hope, and I'm doing all that I can. The interesting thing is that after IVF, IUI, IVF, Clomid, all of the above, um, did not conceive, and then just naturally conceived after I finished my master's program in counseling. I don't know what to tell you. So sharing your story gives other people, some information, hope. It also connects you to other people that really, wish you well, really, really wish you well. And so I feel that it's important to trust and share when you can. It really makes a difference. All right, next slide, please. So some coping strategies for couples. Um, there are a few here that I have indicated: strengthening communication. And what I mean by that is learning about yourself. This is a learning process. This journey, is going to really teach you a lot of things about yourself, but a lot about your partner. So when you are communicating, it's important to keep in mind, are you communicating to learn about one another, or are you communicating to teach one another? I mean, sometimes, it's important to just listen and learn. A lot comes out of conversations when you are using active listening. You may have heard of the term active listening before. It's really listening and trying to clarify what they're trying to say. It allows you to understand their different coping styles, their fears, their solutions and support that they may need, and vice versa. That's what your partner would be doing to understand you. So allowing the other to speak while you are listening is, I think, a very respectful and important way of developing clarity in the relationship. And so that really strengthens the bond. And I have couples create structured check-in times. Like, in our busy days, we have work, we cook dinner, we're just like in this like cycle, and we rarely check in. Sometimes some do, but I do suggest, during the week to have a check-in time, just like we have one-on-ones with our supervisors or coworkers, or we have meetings. It's important to just put everything aside and talk about some of the things that are a bit heavy, right? That we carry with us throughout the week. So a weekly check-in with your partner, it could be 15 minutes or 20 minutes or less. It doesn't matter as long as you have that consistent time to check in and talk about some important things. This is a, very good time to learn about each other when you have these check-in times. And you can discuss things with undivided attention using I statements, and this is how I feel, rather than, you. It's just like really talking about and expressing your own feelings. How you feel is very important for your partner to know. Right, next slide, please. Okay. Emotional intimacy. So it's really a good time to create emotional intimacy. What that means is just really connecting with each other's thoughts and emotions in a very non-judgmental approach. And it's, time together for the sole purpose of connecting with one another emotionally. We do get into the cycle of intimacy may only mean, okay, time, baby making time, which is, that's fine, but it just becomes the only, like the definition of intimacy becomes just that. And I feel that we forget that emotional intimacy is very, very important as well. Just the going for a walk or the hugs or holding hands. It's just like it's intimacy that's necessary as well. And so we talk about the date nights, just avoiding the focus of fertility, but just like to connect with your partner, express appreciation for each other more often, and then also aligning on treatment plans for limits and timelines, understanding each other. Again, we talked about that earlier, just really using active listening so you can understand what the emotional and physical fears are, financial fears, using the I statements. So this is going to be a very important area to grasp when we are talking about coping strategies. Okay, the next slide, please. Thank you. So creating emotional boundaries is also very important I think it's just to protect yourself from getting triggered. What are triggers? Those again are defined by you. What triggers you? What activates different kinds of emotions? Remember, it would be very stressful and triggering for me to be invited to all these baby showers and Amin's, our first baby birthdays and stuff. And I was so happy for my friends and family, but it was very triggering for me. It's hard to also create this emotional boundary, but I feel that if I had learned to do that, I think I would have saved a lot of my energy. And sometimes, if you don't do that, then you feel emotionally drained. So this is one coping strategy that would help. For example, declining, just questions that people ask. It's not a good time. I don't feel comfortable talking about this. I just do remember just elderly and God bless them, but just pointing to my stomach, when's the baby coming? Literally touching my tummy, where's the baby coming? And it's not that they're out there to make you feel bad, but it's just the whole timing of it. You're already just feeling so emotional, and that behavior is just very triggering. So sometimes you do need to avoid putting yourself in those situations. And that is something that you and your partner will talk about, and help each other. This is what I need, and your partner will say, this is what I need, and both of you come up with a plan to to support one another during these times. Okay, the next slide, please. Yeah, and self-care is so crucial. Self-care and couple care. So again, for your own self, you're advised to really reflect on what it is that you need for yourself. And then, whether it be therapy or journaling or any sort of prayers, meditations that work when you are feeling, um, stress. And I think it's important to continue that routine. And that way your partner may either learn from you or just, and give you that space because that is what you need. And the other, and then your partner would also have their own coping strategies. Staying connected with supportive friends and family, and to really ask yourself that question, who are those people that will be very supportive for me? um, and literally just thinking of them and putting a list together. Not all people can support you, uplift you, not because they don't want to, it's because of the capabilities. And so it may be a good idea to avoid interacting with them when you do feel low and you do need to be uplifted. All right, not the last slide. We have 3 more slides to go. The next slide is now talking about seeking professional support. Of course, therapy, and there are lots of fertility support groups as well. Back in the day, there were forums and group chats and whatnot, and very limited things out. But now we're just alhamdulillah, we're actually very we're full of resources. We have a lot of resources. So I think that's not going to be a problem to find a support group, find classes, find people going through infertility. But as far as therapy is concerned, the couples therapy part is so important just because you have a facilitator who can support you and your partner in communicating with one another, bringing out clarity, bringing out feelings that maybe it's really hard to discuss without the support of a therapist. So I always encourage that for couples. All right, next slide, please. And let's see. We got a lot of resources here. I was looking at Resolve and just checking out their website. It's full of great information. So please do check out resolve.org. There are different kinds of groups in your area. I was trying to do Bay Area and closer to Palo Alto, but I haven't checked out all of these different resources, but what I would suggest you do, and because funding is, changes and these contracts change and grants change, some support groups are around and some aren't. I would go ahead and try to reach out and see if if they exist or not. Some are, and so I would look at definitely Resolve. I would look at the different, of course, UCSF, Center for Reproduction Health, and then Palo Alto Medical Foundation, Fertility. And they're just way more information on the web. I'm very familiar with Alameda County, and I'm in Contra Costa right now, but I worked in Alameda County. And if you have county funded health insurance, Medi-Cal, there are also a lot of support groups and therapists that take Medi-Cal as well. Okay, the next slide, please. And this is just a slide showing my information. I do take insurances, so that's helpful for a lot of clients. And I have in-person and video sessions, as well as weekend and evening availabilities. So I do see individuals, couples, and kids, and elderly communities and families. I speak Urdu as well, and so I'm here to support you. I'm here to even look up different resources for you, even if it's not in my area. Just want to be a support for all of you. Any questions that you may have, you feel free to call me and email me. Look at my website, and if there's anything I could support you with, I would love to do that. This is a journey that it's hard to go through alone, and I want to be there to support you. So thank you so much for allowing me to spend time with you today.
Thank you so much. Okay, thank you so much, Sister Wajiha and Sister Atana. It was a great session, and there is a Q&A link that was shared with you, and I just checked, and I noticed that there are many questions asked. I wonder if you had the chance to take a look at them. I noticed that there are questions related to the psychological, but mainly it's on the medical part. So I want to invite Dr. Asiai back. So would you be able to take a look at the questions yourself? I appreciate it. Oh, actually, we can see them here too.
So should I start from the top here?
Yeah, whatever. I noticed that some of them, they were also covered in your talk. But
Yeah,
so
I'll
just-
go over some of them again. So
Yeah, because we only have, I guess, 15 minutes.
Sorry?
Ajit, we have 15 minutes? Yeah, we have 15
So,
minutes.
and we can take questions from the audience too, but I'll just start with these. So is AMH an absolute indicator of fertility chance, or should it be combined with other factors? Yeah, it definitely needs to be combined with other factors because again, like for example, if the tube is blocked, that has nothing to do with the AMH. And your AMH could be beautiful, but if the tube is blocked, you're not going to get pregnant naturally without an intervention to fix the tube. And one other question I saw later was about the number for the AMH or the FSH. There are certain cutoffs that we use. So for the AMH, we like it to be greater than 1 and FSH less than 10. So those are just some very general cutoffs that we use. But again, these are not absolute. So I've had patients with an AMH of 0.2 who end up with a live birth, but after 9 egg retrievals, right? And so how you get there, and like Dr. Waji had said, like this is a journey. For some people, they have one small intervention and they have their live birth. For other people, it's 7 years of struggle, years of procedures, surgeries, multiple egg retrievals, and even after all that, they have one embryo. And I have someone I know like this, and that one embryo takes and it works and they have a baby. And for others, it doesn't end up in that favorable direction. You can have years of infertility and unfortunately not end up with that live birth. And someone had a very good question on here about family building in another way, which I failed to mention, which is adoption. And that is, of course, a very beautiful and viable option for building family. And so, the question specifically was, what are the difficulties with that? I think that's a whole nother talk. So, I won't go into a lot of detail about it, but there, just briefly to address that question, there's domestic adoption and there's international adoption options. Typically, you work with an agency. There's a home study portion that is done. And once you're cleared, that you wait for a match. And then at that point, you connect with the child and can adopt a child in that way. So that is I'm glad someone brought that up because that is another way to build a family that wasn't in the slideshow. Side effects for Clomid. Multiple side effects can, include headaches, abdominal pain, nausea. Most women tolerate it well, though, because you actually only take it for 5 days of the cycle. The main one I counsel patients on is the risk of twins. So there is about a 6% risk of twins. So that's something you want to be okay with before you do ovulation induction of any type. Let's see. How about treating fertility with medication only? Can it be effective? It can be if the issue is something that could be treated with medication. So if it's an ovulation problem, often if we treat with ovulation induction, and if that's the only issue, then it could work. If it's a sperm issue, we sometimes can give supplements and or reduce a trigger. So I had one patient whose partner was using a lot of marijuana and had zero normal morphology. And after he stopped for 3 months, it was great, and they had a baby. So sometimes it can be one simple intervention, but other times it could be a number of factors that need to be addressed. It's really depends on the situation. Is there a concrete study on how long a female can wait based on her lab data? So that's I mentioned the AMH and the FSH cutoffs, which is what we use. You know, you can feel generally safe that you can wait, you know, at least a year or two, and then I would recheck it because these do change. The AMH in particular is one that changes and fluctuates quite a bit. Can you use can the use of menstrual cups lead to uterus adhesions? No. So these are not entered into the uterine cavity. So the common cause of uterine adhesions would be if you've had instrumentation of the uterus, so like DNC, postpartum hemorrhage that hasn't been resolved quickly. That blood that stays in the uterus can cause scarring of the uterus. So those are the common causes of scarring. Is there a study showing correlation between the quality of eggs and sperm with the general health of the baby? Yes. So this is why we see the risk of miscarriage, Down syndrome, aneuploidies, trisomy 13, trisomy 18 increase as we age because of most of the time because of the egg quality diminishing. So it is important to, unfortunately, there's not a lot we can do to improve the egg quality. Aging is the main risk factor for that, but we do use supplements to do what we can to reduce oxidative stress and decrease inflammation in the body, and all of those things could potentially improve quality. There's also something called PRP that can be used. And so there are some interventions that we're seeing can improve egg quality, but unfortunately, there's not a lot. Having a child earlier or freezing your eggs earlier is really the best way to decrease that risk. In terms of the embryo quality, though, those are graded when you do IVF. And so the embryologist will actually look and give a grade to the embryo. And oftentimes people will choose to transfer the one that looks like the highest grade or quality. That being said, I have delivered babies that were, you know, they were told that the embryo had what's called mosaicism or some abnormalities, and then the baby's born and no problem is seen. So it's not a perfect correlation. You had a question?
Question related to this question, is it increasing the age of the female or male contributed to the
So to which one? 21. Trisomies, most of these Down syndrome are from the egg. There are certain genetic conditions. I believe Noonan syndrome is one of them. There's a few.
The mother or mother, but age is important.
The mother's age is usually the most important for like Down syndrome specifically, but there are certain conditions where actually the male age plays a bigger role. So some genetic conditions like Noonan syndrome, there are tests that I recommend in pregnancy when I see that the partner is much older. So once a woman is pregnant, there are panels of genetic tests you can do. And if the male partner is older, there's certain ones I would recommend in particular that would screen for those conditions. What is the success rate of IVF? So if the eggs and sperm are healthy, what can still go wrong? And what is the success rate of IVF-induced pregnancy in that case? So in general, we quote like 50% chance of success. But again, there was that graph I showed. It also is dependent on the age of the egg in particular. So not really the age of the woman, but the age of the egg that you're using. And the guidance that REIs typically give is that for one live birth, try to have 3 embryos. So that is kind of the average 33% you kind of think of as the chance of success with each transfer. So you can transfer an embryo and have a failure, so no pregnancy. You can transfer an embryo and have something called a biochemical, which you have a little bit of a pregnancy that takes place, but then there's no actual pregnancy seen on ultrasound. And then there's obviously miscarriage that can happen anytime in the pregnancy. And then the ultimate goal is live birth, but there are all these other things that could happen when you transfer that don't result in a live birth. And then the question was like, what other things could be wrong? Well, one of the things I highlighted was endometriosis. Like that is something that oftentimes the REIs will actually refer patients to me to evaluate for and treat because they've done so many transfers and it's not working. And so they want me to really make sure that I remove all of the inflammation in the woman's body to make sure that there's no septum in the uterus. And so that's where the surgical portion can come in. And it is, some REIs are more proactive before they even do a transfer. They'll do tests for endometriosis, and if they see they have it, they'll send patients to me to have the surgery even before they do the first transfer. Especially if you're someone who only has one embryo, right? Because it's a luxury to have 20 no, it's very rare that anyone would have more than like 8 embryos because there's an attrition process that happens from gathering the eggs to actually getting one genetically euploid embryo to transfer. So many times people only have 1 or 2 or 3. And so the REIs really want to make sure that if they're putting that embryo into the uterus, that the body is receptive and ready and primed to carry that pregnancy to term. So sometimes we do need to do surgeries before we even do the transfer process after we've retrieved the eggs and made embryos. What is the success rate of egg freezing or embryo freezing? Meaning if you can successfully freeze eggs or embryos, what is the chances of getting pregnant that way? So again, dependent on age. So if you are doing, so I think that question is basically asking for the chance of success of IVF. So if you're under 20, your chance is going to be much higher. So 50, 60%. Over 40, it goes down to about 10%. So again, age of the egg plays a big role in that. And then the success rate of egg freezing. For each egg that you freeze, that has about only a 5% chance of making an embryo, making a baby. So that's why we try to freeze as many as possible, usually 20 to 40. So that means some women will need multiple retrievals to ensure as much as possible that they can even get like one live birth because of all of the things that can go wrong and all the attrition that happens to get to an embryo. So it's actually a very low success rate from egg freezing. It is better with embryo freezing. I'm not an REI, so I don't know all of the statistics off the top of my head with the embryo freezing. But the chance is higher if you freeze an embryo versus freezing eggs to get to pregnancy. Sharing is so this is a question for Wajiha. Sharing is therapeutic. How do you do that when people are judgmental and have cultural expectations and standards?
I think yes. Oh, is it echoing here? Can you hear me?
Yes, it's fixed. Anyone connected to Zoom? Please, can you repeat the question?
The question is, sharing is therapeutic, but how do you do that when people are judgmental and have cultural expectations or standards?
I think, this is a good question to bring up also in therapy. So therapy, and it's, using therapy is a non-judgmental space. So it's very important to have that. And then it's about just really assessing, who is able to provide the support you need. Like I did say earlier, that not everyone has the capabilities. They're not ill-intended, but just not able to. So it's also very important to discuss that with your partner, with the therapist, as to how to share, and which selected people to share with, and how much information, right? Because not a lot of people can't give you the comfort and the encouragement that you need. So I think it's important to really evaluate who you can share with. Again, in therapy, that would be a very good topic.
What does it mean to avoid heat exposure for men to prevent infertility, like to not be in hot water? How hot are we talking about? So this is referring to avoiding, especially during the time that you're trying to conceive. So it doesn't mean your whole lifetime. The sperm cycle's 3 months, every 3 months. So what you did 3 months ago is unlikely to affect the current sperm. So hot saunas, hot tubs, these are the things that I mean by avoiding heat. The other things like not putting your laptop on your lap when you're working, long bike rides. Really, that's it. Those are the main heat exposures that we counsel men about. Adoption, we talked about. Fostering is another good option. Thank you for bringing that option up as well. Is egg donation fine? This depends on who you follow. So not all Muslims agree on egg adoption or sperm donation. In Iran, it is allowed in some places. So depending again who you follow, that would be something to discuss with your Islamic leaders to make sure you're on the same page with that before you move forward. Surrogacy is also done in Iran as well. And surrogacy, when you have another woman carry your embryo for you. So it's called rahim ejari, renting the uterus is the translation.
In English.
And then do you have to make sure that the donor is Muslim? Yeah, I don't know the specifics of that. I would speak to a religious scholar about that. Again, I'm not an REI, so I actually don't do any of this portion of the fertility treatments. What's the definition of infertility in defining 1 in 6? So that's going to that textbook definition that after 12 months of unprotected intercourse under the age of 35 or 6 months of unprotected intercourse over the age of 35, not conceiving. That's where 1 in 6 couples will fall into that category. Can you test eggs after they're thawed, as well as sperm quality after frozen? Or are they tested prior to being frozen? That's a good question. No, you can't test the eggs. That's one of the problems. And you can assess the sperm, but you don't necessarily know what embryo that's going to create. So that's why if you have the option, if you have a partner who you want to start a family with eventually, I highly recommend embryo freezing, which you can test the genetics for and check the quality for, as opposed to separately freezing egg and sperm. Yes.
So for the definition that for the previous question,
Mhm.
so in that case, every couple will eventually experience infertility, right? So because over the age of 35, I mean, everyone at some point becomes infertile, right? I mean,
So not necessarily, because I mean, oftentimes couples are using contraception. So this is couples who are not using contraception, who are actively trying during their fertile window to get pregnant. So even after 35, you should eventually get pregnant.
but you mean, but for example, someone who like is 50, like for
Yeah.
example, they are infertile anyways, right? So are they
Not a man, but for women, yes, once they meet menopause. This is for reproductive age women.
okay?
Yes, yes, yeah. But men can actually conceive, as we see with some celebrities at very late ages. So can you explain a bit about child's genetic problems in relation to the parent's age? So generally, I think I spoke to this a bit. So we do see aneuploidy or genetic abnormalities increasing with age, predominantly woman's age being the biggest factor, the age of the egg, but also a smaller proportion of genetic problems due to aging of the male sperm as well. The one we think about the most is Down syndrome. And the ones we test for when a woman is pregnant are Down syndrome, trisomy 13, and trisomy 18. The reason we test for those 3 specifically, as opposed to all of the other aneuploidies, is because those are the ones that can make it to a live birth. And so we want the couple to either have the option to terminate the pregnancy early on if they determine that they want to go in that direction, or prepare to have a child that may not live after a few days of birth, which we see sometimes with trisomy 13 and 18. Or like trisomy 21, they can live a life that is full, but it may have a shortened lifespan, or the child may have multiple medical conditions. So they may want to prepare for that if they do choose to keep a child who has a genetic condition. So those are the ones we test for primarily.
When does this test?
Usually around 10 weeks of pregnancy. Yeah. Or if you're doing IVF, you can test it at the 5-day embryo stage. And then you can decide which embryos you transfer back and which ones you discard. Next question was, can you test eggs after thawed? I think we talked about this already. That's a cute onesie. Where can I purchase it? I just found that online, but I did find a very cute store next to, do you know the exact address? It's on El Camino and Grant Road is it's a 4D ultrasound place. They're run by Muslims, and they actually have really nice onesies that do have some Islamic text on it, like Alhamdulillah, or some nice onesies. So I would recommend checking that out.
We'll put in the resources later on.
Next question was, when you show the data regarding the correlation of female age and infertility, it seemed like the data is based on the birth given, not necessarily infertility. Could it be that just fewer women are giving birth as they're getting older, because that's how it always has been culturally, not necessarily because of infertility? Could you explain what the metric being used is as an index of infertility in the graphs that you showed? So those graphs are specifically looking at women who were trying to conceive. So this is not just like general population, and they have age match controls. And so that's how we know that specifically the fertility declines as you get older. And it absolutely correct in that it's the data is based on that. In that particular graph is live birth. I didn't go into miscarriages in this talk because that's a whole nother topic. But we do know that the risk of miscarriage just does go up, also correlating with age. And so that would also impact the live birth rate that we're looking at. What are the long-term effects of IVF? That's a very good question too. I mean, the IVF, we've only been doing this, since the 80s, 90s. So we don't have a lot of very long-term data yet. But there are some concerns about, especially women who are getting multiple cycles of IVF, getting multiple hormone injections over the course of many years, potentially having increased risk of breast cancers or certain hormone-driven cancers. So it's not something that we necessarily it's not a huge risk that we're really thinking about right now. Like, we wouldn't tell a woman not to do IVF because of a risk of breast cancer, but it is something that we're studying more and we're keeping an eye on. And it's something to, especially if you're having multiple cycles, to be aware of and to make sure you're doing your breast cancer screenings. Can someone adopt from Iran or Pakistan or Palestine? So I actually do know a little bit about this. So you can adopt from Iran, and I don't know about Pakistan, but I know from Iran you can adopt. There's one agency called Hopscotch that works with placement of children, orphans specifically. They have to be orphans in Iran, and you do need an agency here or locally, wherever you live, to work with Hopscotch. And you do have to live in Iran for about 6 months after you match with a child. You have social worker visiting, make sure it's a good match, and before you can travel back to the US. But it is possible. I actually have a few colleagues and friends who have done this recently. And if you want more information on that, I can talk to you about it afterwards. In terms of Palestine, you cannot adopt from Palestine. The only information I have found about this is going to Egypt, and I think there's an agency that has Palestinian refugees in Egypt that you can adopt. And I also do have a contact for this if anyone is interested. Does premature ejaculation result in infertility? I'm not a urologist, so again, I don't want to speak too much on male infertility. I believe this is a factor in infertility, but I don't have specific numbers or anything. But if you have more questions on that, I would talk to your urologist. how can you get these initial screenings when most doctors won't recommend them unless you've been trying for at least 6 months? Yeah, that is a problem. A lot of the time, doctors want to stick to these guidelines, and sometimes you have to just say, look, I want this test. I am willing to pay for it. Please order it. And if you're very direct and persistent, hopefully you can get that order done for you, or you can get a second opinion and try to find someone who is a little bit more lenient. The main barrier for doctors is that insurance may not cover these tests. And so we sometimes get backlash from patients when we order tests and then they get a $400 bill that they don't want to pay. So it's a little bit of a conversation that you have to have in terms of what you're willing to pay for to get this investigation done. Should I keep going? I don't know how many. I should. There's a lot more.
It's a lot more, yeah. We can,
There are, I guess, there are 6 more, but as you wish, if you want.
Yeah.
I can keep going, but I don't know. I don't know
We
what
can
time we
probably-
usually end.
maybe we can 5 minutes.
Yeah.
Sure, okay.
Wrap it up in 5.
So should we reach out to our GYN physician in terms of checking hormone levels? Can we ask our GYN physician to request these tests, or there should be clinical indications to check these hormones? You can ask your general OB/GYN to check these levels. If they refuse or they don't feel comfortable, you can always ask for a referral to a reproductive endocrinologist and fertility specialist, the REIs that I mentioned before, and they would be happy to order those for you. Really, the main issue is cost. So just being aware of that. A lot of insurances have infertility as an exclusion. And even if you don't meet the diagnosis yet, the REI may use that code, and so you may get a bill. Now, there are some updates with Governor Newsom signing a bill saying that a lot of commercial insurances need to cover some infertility benefits, so hopefully that'll change, but insurance may be slow to actually pick that up. But I know a lot of groups, tech companies, Facebook, Google, they do have these benefits. So that's another point actually to make is, especially if you work for one of these companies, please investigate your fertility benefits and make the most out of it, because these are very expensive treatments, oftentimes $20,000, $30,000. And if they're willing to cover it and you want to delay your fertility, that is a good option to take advantage of. Any IVF center in the Bay that you recommend? I work with a lot of them. Dr. Amy Avazadeh is in San Ramon. She's exceptional, very out of the box thinking, especially if you've been on this journey for a long time and you're getting nowhere with your current treatments. I'd recommend seeing her for a second opinion. I often work with CCRM, Spring Fertility as well, RSC, RMA. There's a lot of good options. I usually just see where people are located because, especially for the IVF portion, you do have to go very frequently for ultrasounds prior to your egg retrieval. So it is helpful to be nearby your IVF center. And then what does the sperm washing involve? How does this distress impact fertility? So once the specimen is provided, it gets spun, and then it's washed at that point, and then they actually give the specimen back to you, and then you bring it back to your office, to your doctor's office, where it'll get inserted into the catheter and then placed, into the uterus for the IUI. So generally this improves the quality of the sperm, and we don't see it having a great stress for the sperm itself. And then, until what age can a woman use embryos to try for pregnancy? Yeah, that's a great question. Some IVF centers do have cutoffs for IVF. So now this question is talking about embryos, but in terms of whether or not the IVF center will even try to retrieve eggs from you, some of them have 40 as a cutoff, some of them have 44 as a cutoff. Dr. Amy actually doesn't have a cutoff. She will counsel you that your chance of getting eggs, over 44 are going to be quite low. So it may not be worth it to you to undergo the cost and the pain and the stress and all of that things that go into it. But if someone wants to try, she will work with you. In terms of the embryos though, transfer age limits vary. I've seen them transferred in women age 50 in residency. I heard of a woman who was in her 60s who had an IVF transfer, but that's quite rare. Usually IVF centers stop around 45 or so. Let's see. What kind of preparation do you recommend before starting IVF? So again, I'm going to mention Dr. Amy. She actually has classes online that you can access. She has a podcast, she has videos. I think it's really important to talk to your doctor or access a resource like that where you can learn about the process. There are infertility support groups that I recommend joining. There are a lot of them that are online, virtual, some are in person. It can be quite a stressful process, especially if you are not immediately successful. So it is good to have those support networks in place and do as much reading and education on the process before you go into each procedure. And also just taking it one day at a time, because it can be overwhelming when you try to think about all of the steps involved and all of the procedures involved, all of the medications.
Okay, thank you so much. A quick question they have asked in the chat about Dr. Amy. They want their
Yes.
surname.
Oh, it's
Oh,
Farsi.
this is for C. Yeah.
It's spelled A-I-M-E-E, and last name is Eyvadzadeh, Eyvadaddeh. Dr. Amy is what she goes by. She's also known as the Egg Whisperer on Instagram, and she's Iranian, clearly.
Dr. Amy Eyvadzadeh.
Yes.
Yes, very good. I really appreciate your time. Thank you so much for coming. And also we appreciate you, Dr. Khan, for attending this online. Thank you
You're
so much.
welcome.
Sharing
Thank
this
you.
insightful comments. If you have any last comment for us, let us know.
I appreciate it, and sorry I couldn't be there in person, but maybe next time I would love to meet all of you in person. Thank you for allowing me to just to share some information and resources.